So this is a 28-year-old man, married for 2 years, trying to have a baby with his wife. They get a semen analysis elsewhere, and it shows no sperm moving. Lots of sperm, but just sitting there.
So for several reasons, I put him on testosterone, and when I saw him back recently, he said, my relationship with my wife is better, and let me tell you why. He had stool coming down his leg, and I just felt so terrible. And I know that like fecal incontinence is certainly different from urinary incontinence, but I felt that deep in my soul.
What I have had the benefit of seeing is, and I've just heard this so many times, that after these patients get their incontinence fixed, they'll say to me, why didn't I do this 5 years earlier? This has made such a huge difference. Some of these people are like, this is like night and day. When it goes from 10 pads to 1 pad, all of a sudden, you know, what they can do and their ability to get back into what their life was before, or even close to it.
Welcome to Fertility and Other F Words, the podcast that tackles fertility, sexual health, and everything in between. No topic too taboo, and no question off limits. I'm Dr. Amy Pearlman, board-certified urologist with expertise in sexual, hormonal, and genitourinary health, and co-founder of Prime Institute in Miami, Florida.
And I'm Dr. Larry Lipshultz, a board-certified urologist, specialist in men's health and fertility, professor of urology at Baylor College of Medicine, and head of the Division of Male Reproductive Medicine and Surgery.
All right, Dr. Larry, so you had a busy week this past week. What you got? Anything good?
Yeah, I did see a very interesting case that I wanted to run by you. So this is a 28-year-old man, married for 2 years, trying to have a baby with his wife. They get a semen analysis elsewhere, and it shows no sperm moving. Lots of sperm, but just sitting there, right? So
let me ask you a question really quick. I got to ask the godfather of andrology here. So when you see no sperm moving, does that mean they're dead or just not moving?
we don't know yet.
Okay.
Good question.
Thank you.
So then we have to see, are they moving or not? I mean, are they alive or not, right? So there's a couple ways. You can put them in a sugar solution, 35% sucrose. If the tail swells, they're alive.
Okay.
Or you can use a vital stain. If they stain a certain way, they're alive. Both techniques, 60% alive. But they had already failed IVF twice. So one of the things that I started thinking about, you know, I've seen this before, and the most common reason is that the tails of the sperm are lacking the intratail, I guess you would call it intratail, microtubules that they need for motility. So I went and I looked online, and what are some of the causes? And the most common cause of the sperm not moving are tail defects. But more importantly, thinking back to when we dealt with this in our lab, those people did not do well with IVF because the genetics of tail defects may be affecting other aspects. So my next step is, as you know, we do whole genome sequencing. So I've already sent his blood over to get sequenced. I'm going to see if my PhD who runs our lab is going to pick up some of these abnormalities.
So let me ask you this, Larry. Why should people watching care about this scenario? If someone is going through IVF or their infertility journey, what's like the take-home point? Because I feel like there's something that you're not saying that you want to say that should be very obvious to people.
Well, the obvious thing is, you know, the definition of insanity is doing the same thing over and over again, the same way, and expecting a different outcome. This man should have been referred sooner for evaluation because it may change his management significantly with these genetic abnormalities.
Yeah, that's a really important point. And that emphasizes, I think, our message for a lot of these episodes is when a couple is going through infertility, it is a couple's thing.
Always.
Right? So it's not always like an issue with both people, but both people really need to get a workup.
And I also think just emotionally, I don't like this, it's your problem. No, it's my problem. No, it's a couple's problem, and they both need to be evaluated so they can shared responsibility. I think that's important.
Yeah, that's really important. So I had an interesting thing in my clinic.
What was your interesting thing?
My interesting thing in my clinic. So both of us treat a lot of guys who have low testosterone, and I recently put a gentleman in his 40s on testosterone therapy, and he had been seeing a therapist with his wife for some time now, and I think a lot of her message was like, I need help with the kids. You know, but for him, it took him like an hour from when he woke up in the morning to really get himself together where he felt like he could start his day.
How old is he?
He's like in his early 40s.
Okay.
Yeah, early 40s. And he sees my sister for medical weight management. He's on a GLP-1 medication. And so he was seeing me for low testosterone levels, and we wanted to maintain his muscle mass as he's going through his weight loss journey, right? So for several reasons, I put him on testosterone. And when I saw him back recently, he said, my relationship with my wife is better, and let me tell you why. When I wake up in the morning now on testosterone, I'm ready to go. So I get out of bed. It no longer takes me an hour, and I'm helping get the kids ready for their day and ready for them to go to school. And that has completely changed the dynamic with my wife.
Yeah, lifestyle.
Yeah.
Big impact on his lifestyle.
But I see for so many guys and women, when we optimize their hormones, when they wake up, they're able to start their day. And I think that is priceless.
It is. It's very important.
Yeah.
And you've helped them in a very simple way.
Yeah. So I'm excited to get into today's interview because we're going to really focus on quality of life concerns, really, the focus of a lot of our podcast episodes, but particularly with a topic that a lot of people are not talking about.
Yes, and especially how it impacts men's life.
Mm-hmm. All right, Larry. So why don't we get into some breaking bedside news, shall we?
Well, one of the things I've been doing, I've been noticing that I'm seeing more couples, women especially, with premature ovarian failure. And it's heart-wrenching because these people are perfectly healthy, try to have a baby, and they're told, no more eggs, or very few eggs.
And how old are these women?
How young are they? Anywhere from 35 and up, maybe even a little younger.
Yeah.
It's really scary. So anyway, another problem is there's no treatment, right? So what several of the couples are starting to do is to go elsewhere for platelet-rich plasma injections, which I initially poo-pooed.
Yeah,
right?
we've had this discussion.
I've
You're
said
like,
that.
come on, what's
this
going on here?
This is crazy, right?
Yeah.
So I went to Open Evidence,
Ooh.
a great source of scientific information, I think. And I asked them, I said, what do we know about this? What is the scientific data? So to quote a couple things, there is emerging but low certainty scientific evidence suggesting that intra-ovarian injections of PRP may improve some markers of ovarian function in women with premature ovarian failure. Some evidence, right? I read on, the overall quality of evidence remains low, with most studies being small, uncontrolled, and retrospective. So it's an experimental therapy with some promising preliminary data. So that's what caught my eye, promising preliminary data, because there is no treatment for these women, and it's not going to make them worse. It probably is expensive, but it's not going to make them worse. So then Open Evidence sent me to an interesting article that I pulled, and it's from the European Journal of Medical Research, reputable journal, and it talks about the exact same thing. It's a systematic review, meta-analysis. Bottom line, it may work in some women. It's emerging, and my feeling is, why not?
Yeah.
Right?
Well, I would imagine that the people that are offering this to women are in a similar situation that you are when it comes to men, and you see these guys who have no sperm in their ejaculate. You go into their testicle and you find no sperm, and the last thing you want to do is say, "I have no more options. I cannot help you."
Right.
I think sometimes for a lot of things in medicine, we try things that are still investigational or experimental.
Yes,
and I think
we've heard from some of our new faculty who talked about these innovative techniques for men.
Yeah.
And I think that these innovative techniques for women are interesting, and I don't think we should just throw them away because they're emerging.
Yeah.
Let's see what the data shows. But I don't have any compunction now, and when a patient tells me they're going to one of these programs, to say, hey, why not?
Yeah.
It might do something.
Yeah, what I think is really interesting is you're kind of changing your habit here, right? And
in what way?
I think oftentimes in medicine, and I'm guilty of this too, is a patient comes in and they say something, and it's something that we were never taught before, and we didn't read the article, and so we're like, oh my God, I can't believe so-and-so would offer that therapy. That sounds like malpractice, or it sounds like they're, offering a procedure that's a lot of money with no evidence, right? And we hear that often, but we don't always do our due diligence. And you simply going online and using Open Evidence and then pulling up that original article, I think is really awesome. I think we need to do that more.
Right, and I said to Open Evidence, show me data with scientific backing. I didn't just say, tell me something.
Yeah.
And it's a very good source for them.
Yeah. I was recently seeing a patient, and they asked me a very basic question. And during the visit, I said, give me 1 second. I just want to look something up real quick. And I went on Open Evidence. And then I told her the information that I learned. And I told her, I just went on open evidence, and she's in the healthcare field. I said, have you ever used it before? It's really fabulous.
Yes.
And she hadn't. And so now she's going to use it. But people don't have a problem with us looking up this information in real time. And when we do this, when we look it up in real time, we are actually giving our patients the most up-to-date information. I think that is some of the most important counseling we could give our patients.
I agree, and it also shows we're really interested in their problems, willing to go the extra step.
Yeah, I love that.
Welcome to today's episode. I am thrilled to introduce our really remarkable guest, Dr. Lenaine Westney.
Dr. Lenaine Westney is a professor of urology at MD Anderson Cancer Center in Houston and director of the fellowship in Urinary Tract and Pelvic Reconstruction. Her clinical expertise includes treating patients with urinary symptoms after complex pelvic surgeries and cancer treatments. A recognized trailblazer, she is a full professor of urology in the United States and speaks regularly about both surgical innovation and diversity in academic urology. Lenaine, it's so good to have you today on our podcast. Thank you so much for joining us.
Thanks, Amy. It's a pleasure to be here. Larry,
Thank you.
I've known a long
Thank you.
time. Thank you too.
So
Long-time
Larry,
friends.
you're outnumbered here. We got two ladies on the show.
I know, but I like it. I'm not threatened.
So much of my practice is being a woman in men's health and treating guys who have sexual dysfunction. And you're also a woman sort of in pelvic health, and you don't just really focus on sexual dysfunction, but you also focus really on overall pelvic health and a lot of men who are leaking urine. How did you get into that space?
You know, it's interesting because, a lot of patients do ask me that, whether they're males or females. And the interesting thing is just like the whole phenomenon of having women in surgery, period, is often foreign to people. You know, my dad was an OBGYN, so it's the reverse. And nobody ever asked him, that question. And actually, I was going to do OBGYN, I think, which is, I think, a very similar thing for a lot of women that go into urology. But, I wanted to have a diversity of patients.
Are you insulted when people say, how are you doing as a surgeon? I mean, you're a woman. Because that comes with the preset thing that you shouldn't be there, right?
Yeah, I mean, I think it's so much less now, fortunately, than it was when I was,
But going
in
back
medical
to when
school.
you were going there.
Yeah, I mean, they were always trying to push you into something else,
Right.
some other specialty. But, when I decided I wanted to have a full range of patients and I wanted something that was surgical, but in the pelvis, then, that's totally urology.
Right.
And it's so interesting that, patients do ask me, how did you end up this? And I'm like, well, we're dealing with incontinence and, everybody has a bladder, essentially, unless they've had it removed for bladder cancer, males and females.
But how does one even specialize in urinary leakage? Because that's not something, you don't go into medical school or residency and say, I want to help people not leak
is
urine.
it urinary leakage or is it pelvic surgery?
Yeah.
I mean, what do you consider?
Well, you do a lot of things.
Well, I mean, for the leakage part, it's really voiding dysfunction.
Yeah.
So people who either can't urinate or they urinate too much. And so you just have to figure out, which it is. But how I ended up here was really my mentor that Larry knows really well, Ed McGuire.
Oh, yeah.
And I was probably going to go into oncology. And he said, why don't you think about, reconstructive surgery and incontinence. And so, he just had a huge influence on me. And then I found that I really enjoyed that. And again, I mean, I saw what an impact it was on people's lives.
think that's
But thinking back to Ed, I mean, he was really into the function and dysfunction of the bladder. So did you get into that space first and then bring in the surgery, or was it at the same time? Or?
Well, I mean, I think that's the foundation of, you have to know how the bladder and the urethra function and why they're not functioning. And then after that point, then you figure out how to fix it.
Yeah. It's so important, complicated. It's so complicated.
Yeah. Well, I think speaking on the mentorship piece is sometimes all it takes is one person to encourage a career decision when it's a good experience. And sometimes all it takes is one person or one comment that completely discourages us from going a certain, direction in our field. So there's a lot of power in being a mentor, right? You mentor a ton of people.
Yeah.
Yeah. Awesome. So let's talk about your current practice. You're at MD Anderson.
Yes.
And, even before we started recording, I was asking you about what are the typical things that you do on a daily basis, and you see a lot of complex patients. So can you describe the common types of patients that you see and their common concerns?
But really, the most common patient I see will be males with incontinence after treatment for prostate cancer, and then also female patients that have either bladder overactivity, and that can be for a wide range of reasons. Since I'm at MD Anderson, a lot of it has to do with treatment for breast cancer. They have a lot of frequency, urgency, and a lot of just pelvic and
But why?
vaginal symptoms.
What is the relationship between the breast cancer and the is it the chemotherapy or what?
Well, it's the medications that they're taking to block the aromatase inhibitors, for example, to block the estrogen. And there are estrogen receptors not only in the vagina but also in the urethra. And so this is often linked to some of the irritative voiding symptoms. And also can be linked to incontinence and recurrent urinary tract infections.
Which no one would really think about because we're talking about two completely different areas of the body. So how do you treat those patients?
They are difficult to treat. So we end up treating them, well, for the voiding problems, often with medications like, oxybutynin, et cetera, for the frequency and urgency. The best treatment for some of the vaginal symptoms and for the incontinence is actually vaginal estrogen, but you have to be careful depending on what type of breast cancer they had and how far away they are from treatment.
Yin-yang, it's
Yes. And that's really going through the FDA right now about taking the black box warning off of the vaginal estrogen. We just had a guidelines panel on the genitourinary syndrome of menopause. And then there was also a meeting with the FDA to try to get the black box warning off of vaginal estrogen.
Let me ask you this on a similar topic. Are there other cancers or disease processes that are completely separate from the pelvis that cause urinary symptoms that people would not associate with being together?
Yeah, I think that people often, they don't associate problems like brain tumors, for example, or having a stroke. Then that can cause bladder overactivity, for example, and actually quite severe urge incontinence. So it's sometimes a surprise. They're like, okay, this tumor's in my brain, but it's making me so that my bladder is now turned into a baby.
Wow. So for these guys that are coming in who are leaking after prostate cancer surgery, prostate cancer surgery has evolved over the last 20, 25 years. Are you seeing that fewer men are leaking urine now, or is the incidence in your scenario still about the same that it's been?
For me, it's about the same, but it's changed. But also, it's not just the surgery. It's also, you also have to include radiation, whether it's external beam radiation or whether it's brachy seeds. And that's not as likely to cause incontinence, but it does if the patient lives for a longer period of time, because the damage from the radiation is progressive. So the changes to the bladder and to the urethral sphincter compound.
I would love to be
over
in the
time.
room when your guys at Anderson have these discussions with the patients about therapy, because
Like the radiation oncologist.
yes, radiation college versus a surgeon.
Yeah.
Because with surgery, the problems are immediate,
Yeah, it's
and
more
then
upfront,
get better
right.
with time. With radiation, paints a very nice picture up front, but then you start down the line, start dealing with these side effects, and I think all too often the patients don't know it's coming.
Right. And another thing that can happen is that radiation oncology sometimes, especially if you're at a tertiary center like ours, may not see the patients anymore after a couple years. Well, they may start having problems 5 years, 10
Right.
years. And then patients like, how could this have anything to do with my radiation? And then you have to go through this this story, understanding about that. Well, it's kind of like a gift that keeps on giving. And over time, you may have more problems.
But do you think that incidence is changing because also the technologies and the precision from the interventional radiologist when it comes to radiation is also getting better?
I think that, that's probably true to some degree. What we're seeing now more so is when you have patients who need to have the combination of surgery and radiation, that's kind of the group that have the most severe incontinence. I think in terms of radical prostatectomy, that the robotic technique has also improved over time in the last 20 years. It used to be that we would have a lot of people that had mild incontinence, moderate incontinence after radical prostatectomy. And I think that has dropped to some degree. It's much, either they have almost nothing or they have radiation at some point after their prostatectomy and it's severe.
Yeah. Those were the patients when I was at the University of Iowa. I was seeing mostly they were dry after their radical prostatectomy, but then they had prostate cancer recurrence, they had radiation, and all of a sudden they're leaking. So do you find that a lot of patients, why doesn't everyone get treated? Why are there still a lot of men walking around who are wearing pads and diapers with this problem?
Well, are there?
There are.
Yeah.
There are. Because, when you look at just in data of the general population, there's such a wide range of the reports or, what is the incidence of incontinence after. And it can be as low as 5%. It can be as high as 75%. And it really depends on which population you're looking at. Are you looking at a single center, single surgeon who has done 10,000 prostatectomies versus someone who was done, in the community? And then it comes also down to the patient's ages and their comorbidities. But that is really multifactorial because first it's the patient. So first, they often do not want to have another surgery, which how can you blame them? And maybe it's maybe getting to be less of a problem now, notwithstanding that there's maybe less of a problem if you have a very experienced surgeon for your radical prostatectomy. But just in general, they don't want to have another surgery. But we are progressing into a time where radical prostatectomy is almost outpatient surgery. Mm-hmm. I mean, it used to be, right. They'd be there for 3 or 4 days, and now we're discharging them, after 24 hours. So that does two things, though. It does make it so that also, especially again in a tertiary referral center, that the operating surgeon is not seeing the patient for as long. They get, as long as their PSA remains undetectable, they'll get turned back to either their local physician and less likely their local urologist, mm-hmm. After maybe even only a year. So if you go back to your local, family practitioner, they have no idea about whether there are really any interventions for incontinence anyway. They've never heard of any sling or artificial sphincter. So they basically, oftentimes tell them there's nothing that they can do.
Mm-hmm.
What is the discharge package that Anderson gives these people? I mean, do they say you may experience this or you may experience that? Do they have discharge education? So the onus is not just on the primary care, or is the patient involved, and do they know what's coming?
Yeah, I mean, they do, I think, do a reasonable job of informing them, about what the complications may be. But, in that perioperative phase, patients are not, they're getting a lot of information, mm-hmm. and that's not one of the things that is, sticking with them, as right. Especially, similar to erectile dysfunction. I mean, I think that sometimes patients are surprised that they have erectile dysfunction when they've had nerve sparing. That this could really still happen. It's like, yes, it can, especially the older you are. But aside from the patient not wanting surgery, I mean, I think there is also some just avoidance and just fear of the unknown. But it's so impactful because... Is there
embarrassment?
It's a huge embarrassment because then, people have a whole set of behaviors centered around whether they're going to leak or not. Where they go, what they're wearing. You can't wear khakis. Mm-hmm. You have to wear dark pants. You go golfing. Someone may notice. So some people end up almost completely isolating themselves because they're afraid they're going to leak.
Let me just go off. So given that all these things, black cloud over their head, worry... yeah. Are there? Do they go to therapy? I mean, are these people sent to deal with this at all? I would think it's a huge emotional thing to have to watch your pants and your diapers, and who do they talk to?
By the time that happens, I don't know that they are necessarily seeing someone who would consider that they would benefit, from therapy. But it would be even better just to have somebody who could, again, give them the options. But, fortunately, we do have more resources now that we have this level of accessibility with the internet. It's fortunate, people can put in incontinence right. and, see what comes back. And I think a lot of, of our, industry is doing a better job about letting people know, what is available, even if you're in a situation or in a community where your health providers, don't have that knowledge base.
Well, I always found it sad when I was at the University of Iowa when I would see a guy who had a radical prostatectomy 10, 15 years beforehand. Somehow he makes it to my office 10, 15 years later. He's been leaking urine this entire time. And when I talked to him about his options for a sphincter or a sling, he's like, oh, did that just come out? And he's surprised that it's been around for decades. And that breaks my heart that this person could have been dry or at least drier many years beforehand. Still, people don't know about this. Yeah. I feel like every person who undergoes prostate cancer surgery should know if you leak, there are options to help you.
But you know what I don't understand? Pharma device companies, their lifeblood is people having issues that they can help. Mm-hmm. So I would think they get out of MD Anderson, they've had a radical. First thing they do is get a care package from what, American, what's it, Boston Scientific? I don't know who makes them anymore.
Yeah. Well, right now for the artificial sphincter, it's Boston Scientific only. For the sling, there's also a Coloplast sling, and then there's another couple other devices.
But wouldn't they like reach out to these people? At least internet, they get the names from the hospital, go after them. I would think this would be such an important part of health education.
Well, there's another thing that happens. There's also the interface of the relationship between the patient and the physician. So number one, if you look at the patient's and the physician's perception of how severe the incontinence is, 50% of the time they don't match. And some of that has to do with the patient failing to report the severity of their continence. Sometimes they don't want to admit it to themselves, but they also don't want to seem ungrateful. This person just, just fixed my cancer. I'm lucky to be alive. But now that patients are living longer, not just in prostate cancer, but in a wide range of oncologic primaries, people, after 5 or 10 years, they start saying, okay, I need a better quality of life. Right now I'm actually going to live. So I need to get on with it.
Yeah. There was a really sad thing that happened in my clinic this past week. So you walk into the building, and as I was like opening the door, there was some stool like on the outside sidewalk, and it really had a bad smell. And I was like, is there a dog in here? I didn't really think it was like dog stool. So I like walk in, and I'm like walking to the elevator, and I see some like stool on the ground going to the elevator. I'm like, okay. So I get into the elevator. There's also some things like in the elevator. So I'm kind of holding my nose. So then the elevator door opens. I'm going to the 3rd floor, and it stops on the 2nd floor. And a gentleman walks in, and I kindly say to him, hey, like watch your step. Don't step in that, And as I like pointed to that, I saw on his leg, he had stool coming down his leg. And I just felt so terrible. And I know that like fecal incontinence is certainly different from urinary incontinence, but I felt that deep in my soul, how sorry I felt for that gentleman who's suffering with not being able to control his pelvic organs. Yeah. And I'm wondering if you could talk a little bit more about some of the psychological implications. And when patients come in and you can help them, how does that make your job so rewarding?
What I have had the benefit of seeing is, and I've just heard this so many times, that after these patients get their incontinence fixed, they'll say to me, why didn't I do this 5 years earlier? This has made such a huge difference. I mean, and it's interesting, for example, for artificial sphincter patients, even if they're not completely dry, they are like so happy. And you imagine, the things that you would, love to do, like travel to Europe. Well, now it's really difficult to get on a plane, but travel to Europe and to have to bring a whole suitcase full of pads and then have to worry about where you're going to change them. So something like that was completely off the table. I mean, so some of these people are like, this is like night and day. When it goes from 10 pads to 1 pad, all of a sudden, what they can do and their ability to get back into what their life was before, even close to it, it's, the horizon, it's
their life changes.
Their life is completely changed.
Yeah. So for the viewers, because they're probably not familiar with what this technology is that we keep describing, if you're sitting down and just like role play with me here for a second, pretend that I'm one of your patients, how would you even describe the options for treating these guys when it comes to a sling and a sphincter?
So for a sling, I mean, aside from showing them a picture, but without it, I essentially tell them that it's like a hammock. Like your urethra is sitting in a hammock and it's like supporting the urethra and it's helping it close. But it's not so tight that you can't urinate. So whenever you're moving around, that it's going to stop the leakage or close to it or substantially so. But when it's time to urinate, your bladder will still generate the pressure enough to push the urine past the sling. For a sphincter.
And really quick, getting back on the sling, because mesh slings are a very polarizing topic, especially in the female pelvic health space. Right. Can you describe some of the, how the differences are in terms of like a mesh sling in a man versus a woman and some of the complications or potential complications? I
mean, the difference in those two scenarios are due to the anatomical differences between a male and a female. Because the woman has vaginal tissue and you're having to open that to put the sling in, that's what makes it possible for there to be an erosion risk or what they call exposure. Or, for example, for either one, the sling can be too tight, but it's much more common in females than it is in males.
So the complication risk for mesh slings in men seems to be way less.
Yes.
And less of a
way
concern.
Less.
Yeah.
It's way less. And there's much less of an infection risk, although, there's always a small percentage that could happen. But typically, I mean, it's way less than 1%.
So excuse my ignorance, but in a woman, I'm sure most of the women are going to be older who are going to have these problems, a little bit older. And if they're going to start changing their vaginal hormones, does this interplay into the likelihood of a good outcome? I mean, do hormones help? Is that part of the picture, or am I totally off base?
Yeah, well, a lot of the older women, although you can have you can have women who have what we would call uncomplicated or genuine stress incontinence as really related to, say, vaginal deliveries. And so they're still reasonably well estrogenized. But in the older women, we would normally have them either like take vaginal estrogen to improve the thickness of the vaginal wall. So that would decrease the risk of exposure. And also, they're also often having it in combination with surgery for prolapse too. So, and that's another one where you want to have the vaginal tissues be more healthy and thicker. You want it to heal. Otherwise, then you can get the mesh exposure. But did you want me to get into the sphincter?
Yeah, definitely. Yeah. Before that,
okay.
though.
The sling.
So the sling sounds great, right? It
yeah.
sounds pretty easy. It sounds like the complication rate is pretty low. So who's a good candidate for a sling in a man?
But that's
in a man.
In a man.
Yeah. But then that's what it comes down to, because the sling is most commonly used for patients with mild to quote moderate, which is kind of a floating definition. When I used to have people do pad tests, and what a pad test would be is to have someone wear their pads as they normally do for a 24-hour period, and then either weigh them at home or bring them and subtract out the weight of the pad. And that would tell me what the volume of leakage was in a 24-hour period. So in that situation, you want it to be less than about 250 to 300 cc's in a 24-hour period. But that sometimes equates to, say, 2 to 3 pads, per day. So someone who is 3 or less and has leakage only related to activity, and it's not overactive bladder, and who, when you look in there with the camera, that sphincter and the urethra look healthy and normal. If it looks all scarred, like from radiation, then that sling is probably not going to work. And also, it's a bit more of an erosion risk as well.
Yeah. So for guys who come in who have more significant incontinence, what are their options?
Their primary option would be, and as well specifically for those who have had radiation therapy, would be the artificial urinary sphincter. So it's a 3-piece device, but the nuts and bolts of it is that it is a valve that opens and closes. So there's a pump that's under the skin in the scrotum. You pump it, the valve opens, the person urinates, and then it closes back by itself over about a minute and a half to 2. So that is the most reliable option for patients that have more severe incontinence.
So it's kind of like a blood pressure cuff that opens and closes around the urethra. So when you describe that type of device to people, is their mind exploding? Like, what are some of the follow-up questions they have?
Well, they're like, what is going on? Well, the questions that I get sometime also are for patients that have a penile device, because they're like, okay, how am I going to be able to tell these apart? And then we have to show them that the pumps are completely different shapes.
So these are guys who also have a penile implant.
Some of those that still have it also have one. They're like, is anybody going to be able to see this? Am I going to have a hard time operating this? For the ones that are more severely incontinent, they're essentially like, I don't care, what this takes. And then I also will have them go to the website of the manufacturer, Boston Scientific, with a Fix Incontinence, and where there are some patient stories, so they can see people who have the device.
Call patients? Do you have patients?
Yeah, I have, and I also have patients that I have them talk to that have it, and then tell them what it's like to have it, every day, and how to live with it. Is it a problem? But in general, people are. I wish I had done this before.
I'm going to ask a very ignorant question.
Please.
Is there anything like that for women?
Well, you can put an artificial urinary sphincter in women. It's just not FDA approved in this country for women, but we do it off-label.
Fairly frequently?
Here, not so frequently. It's very common in Europe, especially France.
Interesting. Where do you put the pump?
The pump goes in the labia majora.
So why is that?
Well, it's because the choices here in America are much more patient driven. And I think in Europe the doctor basically says, this is what you're getting.
Right.
This is your option. We're here. We're like, okay, you can have a sling. You can have artificial urinary sphincter. And, with the more complicated device, I think it's just like with men. I mean, there have been studies, demonstrating that men would prefer to have a sling versus a sphincter, if given the choice. But, based on the severity of incontinence and having had radiation, we really don't recommend having a sling.
How about bulking agents?
Yeah, courtesy of my mentor, Ed, probably have handed more syringes to him to inject what was at that time collagen. And now there are, some other bulking agents instead. We really don't have great data in men. In general, they can work in patients with very mild. And when I say mild, I mean one pad or a liner amount of incontinence, like minimal, 10 grams, very small amounts, and not radiated. It does not work if there's been any energy utilized, in their treatment for prostate cancer, but it can work. Yeah. Bulkamid, which is kind of the current injectable of choice for women. There are a couple investigators right now who are looking at it in men. And so you have to utilize different equipment than you would for a female.
Does it work well in women?
It works great in women. It's really reduced the amount of slings, like transobturator tapes.
Who would be a woman who would get a bulking agent?
Well,
what's her profile?
Someone with kind of mildish stress incontinence. You don't want someone who has like a non-functional sphincter,
right?
But someone with your standard, post-childbirth stress incontinence, or someone, or even an older patient who has mild intrinsic sphincter deficiency. I mean, and now most people do that in the office. So, they don't even have to have anesthesia. So, and it's also great for someone who's, not a good anesthetic risk.
Let's go back a little bit because you mentioned the term stress incontinence. Can you define for the audience, what does stress incontinence mean?
So when I say stress incontinence, I mean incontinence that's associated with what we call stress maneuvers. So that can be coughing, sneezing, bearing down. Sometimes for people with severe incontinence, it can even be rolling over in bed. But it's not something that is related to what we would call urge incontinence, which is just the feeling that you need to go. And it's completely unrelated maybe to what activity you're doing.
It's like the phenomenon where you don't have to go to the bathroom and you reach your front door and you put the key in and you're like, whoa, I really got to go, and you got to run.
Right. And there's a term for that, is latchkey incontinence. And it can also be with running water.
That's so funny that there really is such a thing with the front door.
Oh, any tips for the latchkey incontinence patients?
I think we're getting a little personal here.
I really got to go.
Yeah, it's in that case, sometimes it's mind over matter. So there's a lot of, you need to get some cortical inhibition going. It's like, stop.
Something I found very helpful that I learned from Dr. Fenwa Millhouse is to stand on your tippy toes. And you kind of go up and down real quick on your tippy toes. And I guess that can stimulate the posterior tibial nerve and like quiet down your bladder. I've actually found that to be incredibly helpful. Yeah,
I mean, you need something to inhibit your bladder, the body of your bladder. But, that being said, for your average post-prostatectomy incontinence patient who has not been radiated, CMG is optional. And that was in our last guidelines. So it's not something that is required unless you're having a problem telling whether there is a large component of, say, urge incontinence, or if there is bladder dysfunction. So,
are you still doing Botox? Is that still on your list of things to use in the bladder?
For urge incontinence, yes.
A little Botox here, a little Botox down there.
Yes.
Now some of us are putting Botox in the penis. I mean, Botox I'm feeling it.
It's Botox
what
everywhere.
does Botox do in the penis?
Well, I've seen it. There's not a lot of research on it. It's something that I offer very selectively.
They do it in the scrotum.
I've done it in the scrotum too.
For wrinkles.
Yeah.
Right. It's relaxes.
Some guys are just really into it. I think some people are like, why would you ever offer that? I mean, some guys want it and they do well and it works. So why not? I mean, maybe that's like a little bit of a polarizing topic. In the penis, I found it to be helpful to reduce penile retraction. And they just feel like the penis hangs longer. And a lot of my practice is cosmetic urology. And if I can boost someone's self-confidence, because some guys are very happy with how their penis is when it's erect, but they're very bothered by their penile retraction. So it can help in some of those guys, or maybe even with erectile function. But the research is still coming out for that. Yeah.
Back to the incontinence.
Back to the incontinence.
Yes. It's just like bulbocavernosus relaxation. Just...
I think it's when I actually inject it for retraction, I inject it into the dartos.
So, for dartos muscle.
Yeah. So back to the incontinence, and when I think about my time at University of Iowa and I was doing the sphincter procedures, I would say that's some of the most impactful surgery I've ever done in my entire life. So you see a lot of happy patients. Who are the types of patients that do well with sphincter surgery?
Well, the people that do the best, I think, are those that have pretty severe incontinence but let's be clear, everyone is not going to be 100% dry. So if you have someone who's really almost close to being a sling candidate, they may not be as happy if they still have like a drop of leakage, but someone who's like at 8 to 10 pads, when you get them to 1, they are extremely happy. And someone who does not have a lot of urgency, frequency, or other symptoms that could also be interfering with kind of just how their bladder feels and also causing incontinence. Patients that do not have a lot of other comorbidities like diabetes, that's what we have to make sure that diabetes is under control, because diabetes itself interferes with bladder function, but it also interferes with a lot of just bladder symptoms. If your sugar is out of control, you're going to be waking up a lot at night to go to the bathroom. Also, the diabetes, if it's not under control, is also an infection risk. So we're putting a prosthetic device in. What's
your cutoff at Anderson?
My personal cutoff is 7.
For A1C.
For AUS is for my partner that does IPPs, Ren Wong, his is 8, for IPPs. So, very similar in that regard. But my reason for having it lower is not only because of the infection risk, it's because of the bladder symptoms that it also causes.
Right.
So that, put something in there, it's not, you put the device in there and they're still having problems. And if their sugar's not under control, they'll be like, okay, you need to go to your endocrinologist and get this.
So let me ask you this. For the guy who comes in that says, I want to be completely dry, what do you tell him?
I tell them to be realistic that may not happen. I mean, if you look at the dry rate post AUS or post artificial sphincter, it is 50%, but they will not be dry throughout the lifetime of the device. And for those who are watching, the average lifespan of the device is about 7 years, because as the closure of the device around the urethra, it loosens over time. So when you get closer to the lifespan of the device, you're going to start having some leakage. So I will tell them that you may be dry initially, and that's a coin flip. But just be prepared that you're going to start having a little bit of leakage over time, and let me know when that happens. And if you get to the point, you ever have a point where all of a sudden it's back to where you were before we put in the device, then you need to come back and we need to change the device out.
How often do you change out devices? I mean, in a given, what can they expect?
Well, yeah, I mean, it's true. The average is 5 to 7 years, but I have had some devices last for 14 years. So I just have them check in with me if their leakage, the amount of leakage they're having is changing. So that way they know
what to do. For penile prosthesis, redos are much easier.
Yeah.
How about for sphincters?
I mean, it really depends on what size the cuff or the valve was. For those that have kind of a bigger urethra that has a lot more tissue, and you start with one of a larger size cuff, then you can just kind of downsize that cuff and change out the other components. But if they needed a small one, then I have to move the location and look for some other techniques to get a good fit. So that part is more difficult. But the interesting thing is, since we are having prostate cancer diagnosed earlier in younger patients, I mean, those are the patients that end up starting with the larger cuff, because they overall have better blood supply, their urethras are more healthy. But that also does mean, since they're younger, that, they have to plan to have this, device out, exchanged, 7 to 10 years. So they're going to have several devices over their lifetime, at least.
What is happening on the device side? Are there being changes made so that they last longer, or that the closure is different, or is it pretty stable?
I mean, it has been stable, for 50 years, really. And now we are getting into the electronic devices, for the IPP that should be coming soon. For the artificial urinary sphincter, we are actually starting the trial of the electronic artificial sphincter later this year.
Do you want to tell the audience a little bit what that means?
Yeah. So what that means is that, the legacy device, or the standard artificial urinary sphincter, depends on you squeezing the pump for it to open, and then the system, the fluid goes back through the system and closes by itself. with the electronic device, there is no pump. There is like a battery and like a little can, somewhat like a pacemaker. So that is what is controlling the device instead. And then you have a patient controller. And when you press the button, the device will open and then it will close back by itself. And then the device is adjustable based on what kind of activity you're doing. So if you're doing something more active, it can close more. So that's something that electronic device offers that. Whereas with the standard artificial urinary sphincter, you can't change that. But this offers the ability to increase the closure if you're doing something extremely active. On the other end of the spectrum, if you're sleeping, you can also decrease the compression. So that potentially will increase the lifespan of the device.
Interesting. Give us a ballpark.
Well, we don't know. I don't know that we know, because even, that device was designed in France, and even the patients that have been in those studies, they've had the device for like 2 years or almost 3. So we don't know what the full lifespan is going to be.
But at least you have a working model.
Right.
So we spoke a lot about the surgical interventions, but I want to even take a couple steps back. So for the person, man or woman who's coming in, let's say they have some stress incontinence, maybe they have some urge incontinence as well. What are the lifestyle factors that people need to know to reduce their bothersome urinary symptoms?
Yeah, I think that's kind of universal, regardless of, what the cause of the incontinence is or gender. I mean, we do tell people about considering what they're eating. Sometimes there are triggers that exacerbate bladder overactivity, for example, like caffeine. In some people,
it ain't so.
I know, yeah, I know. I'm like, at least 2 or 3 cups of coffee a day.
Like as you're drinking your coffee, you're like, you're gonna have to stop drinking coffee.
And we, here in Texas, people love their acidic, tomato-based, spicy foods. Those can also be major triggers for the bladder. So sometimes people have to determine whether that is a trigger. We also for those who are waking up a lot at night, adjusting how much they're drinking before bedtime. So we tell people to kind of reduce what they're drinking at least 2 hours before bedtime. But one of the interventions that is more conservative is and I think for men or female, pelvic floor physical therapy. So we refer a lot of our patients to our pelvic floor physical therapist, but regardless, there are a lot in the community. But if you go to pelvicrehab.com and put in your zip code, it will tell you the pelvic floor physical therapists that are in your area. So we have people mostly from the surrounding states, but from all over the country. So what we do is we give them a referral via our electronic medical record and give them some names of some local pelvic floor physical therapists.
That's really important.
Yeah, I'm so glad that you brought up pelvic floor physical therapy. I think they've changed my life, perhaps even more than they've changed my patients' lives. But if there's one provider that I routinely refer my patients to, where my patients come back and they say, Amy, that person changed my life, it is a pelvic floor physical therapist. When do you recommend someone get in to see a pelvic PT? Is this before intervention, after intervention? Do they need to suffer with symptoms for 3 months, 6 months before you send them to a PT? What's your rec?
Well, all our patients get, for example, the prostate treatment patients, unfortunately, the radiation patients maybe don't receive the same instruction as the surgical patients, but the surgical patients do receive instructions about Kegel exercises at a minimum. Our prostatectomy surgeons are very good about referring patients to us fairly early, and they will actually also send them to pelvic floor physical therapy even before they come see me. But in terms of preparing for surgical intervention, we would normally start that consideration at 6 months. But I will not intervene surgically in someone who is, fairly mild incontinence who has not been to a pelvic floor physical therapist. And also, if someone says that, this incontinence is bothering me, but it's slowly getting better, I will generally tell people that they need to stabilize for 2 to 3 months. because we need to wait until they've gotten to a nadir or wait until it's unchanged. And so that we can be sure that they're not going to ultimately improve. Granted, if they are using 8 to 10 pads, the likelihood that they're going to improve enough that you don't have to do an intervention is pretty small. But if someone's using 1 to 2 pads and they're slowly getting better, there's plenty of data demonstrating that incontinence can, minimally improve even up to 24 to 36 months.
Mm-hmm. Awesome. So if we had a megaphone, we don't have a megaphone, but we do have these nice microphones.
Sure.
What would be your message to, let's focus on male patients here. What would be your message to male patients who have stress incontinence?
Wait, in general or following radicals?
Well, in general, because it could be after a prostate
different.
procedure. No, it's the same. After a prostate procedure for BPH, they're still offered the same. It could be offered the same options.
Correct. We should include someone who's had basically any therapy for prostate treatment, because even men who are on hormones, or hormone ablation therapy, that has the same problem, because you are interfering with something that's going to affect their muscle mass and even the muscle mass of their sphincter. So that can also cause or add to incontinence, or the ability or their pelvic floor strength, or the ability for them to have effective pelvic floor exercises. That there are interventions, and that it doesn't have to be something invasive, but we definitely can improve the quality of their life, that they don't have to stay, with the pads, and don't have to become socially isolated because of this incontinence.
Yeah, I love that message.
Important message,
right? Know your options, understand the conservative therapies. A lot of, there aren't medications to treat pure stress incontinence, right? So unfortunately, that's currently the case.
Right.
And there are surgical options that these days, even though they do require incisions, a lot of them would be considered very minimally invasive surgeries that oftentimes are considered outpatient.
Correct.
And you mentioned some websites here where people can learn more information. We'll definitely include that in the show notes. But one that you mentioned was fixincontinence.com.
Correct. Yeah. So, it's very important that when I talk to patients, the one thing that I can't give them is having a similar experience. So I think that's one of the most valuable things, that in addition to knowing the options, that, this is not going to be something where, unless they have a close friend that has a device, and I have now a lot of patients that send their friends, but if you don't have that, you need to know what it's like, for that other, from another guy who's had some kind of
I think that
prostate.
really helps.
Yeah.
Helps patients calm down and kind of know what to expect.
Yeah, because
I
it's
love the patient
foreign,
advocates.
because you're suggesting that someone put something, foreign into their body. And so they just need to know that, it's going to be okay.
Awesome. Well, I love this conversation. We really appreciate you coming on.
Yeah, it was so good of you to
Yeah.
give us this time, because I really think patients need this. I don't think people know much about
There's
this
not a
area.
lot of information on male stress incontinence online that I think reaches lay people. So I
Right.
think this is going to be helpful for people. We'll definitely include the resources. And thanks for joining us today.
Thanks for having me.
Yes, giving us some valuable time. Thank you.
I really loved talking with Dr. Westney today. When I think back at my time at the University of Iowa, treating men who are leaking urine was some of the most impactful work I've ever done. And I love how she spoke about this in a way that's like, look at these options. We have conservative therapies, we have surgical options, but people need to know their options.
They do. And, I see men post-radical prostatectomy, and I see them for erectile dysfunction. But I think the thing that bothers them by far the most is being wet. I mean, you cannot lead a normal life if you're wet all the time, and it changes your whole self-image. So, I think what she's doing is so important for men's health in general.
Yeah, absolutely. And for the final F word, I don't know if there's an F. I don't know. Can you come up with an F word for today's episode?
Free from leakage.
Oh, I like that. I like that. And I think my final thought for today's episode is, if you're a man and you're bothered by quality of life symptoms, you deserve to know your options.
Agreed.
And please do not let it run your life. And even if you're not interested in undergoing a procedure or a surgery, at least you know their options.
And there's medicines.
Yeah. For some types of leakage, there are
Yes.
certainly medicines. So I think that's a really good message. All right, Larry, why don't you give us some foreplay for the next episode?
Okay, so for our next episode, we're going to hear from Dr. Mohit Kira, one of my associates, internationally known, and he's going to talk about lifestyle changes to improve your erectile dysfunction.
I love it. Thank you for joining us today on Fertility and Other F Words.
And please don't forget to like, subscribe, and leave a comment.
Until next time.